Good evening, y'all. I'm Bob Stemberg. I'm in Akron. So I'm excited to talk to y'all. Tonight I want to talk to y'all about needle visualization. And, honestly, what other group could I, dish this as something to talk about other than BlockHeads? So I'm very excited to talk about this. Why do I think we should talk about this? I mean, I think especially when we're doing this with kind of more novice users, I think they really struggle with needle visualization. And I think if you don't have this down well, I think it's a lot harder to kind of explain your block profile too. So I kind of want to just talk about some different things that I've found helpful and kind of see what everyone else is doing. So this is kind of the classic thing that I always see. I feel like I'm just like constantly screaming at residents, be like, "Where's your needle? Where's the tip?" So and ironically too, we were QAing one of our studies today, and an intern was watching one of the blocks I did by myself, and she's like, "Man, if I were doing that, you would be screaming at me." So I got flipped a little bit today, but cheers to that. So just kind of want to go through some different technique pieces, some equipment, and hopefully kind of do a little bit of discussion here. One thing that I feel like people don't quite understand is, footprint thickness does not correlate at all to slice thickness. So as it kind of is demonstrated here, a lot of times that, that beam is only really like a millimeter thick there. So I think it's always kind of good to remind people as they're kind of going through it. And one other thing too that I found really helpful with, when you're kind of walking someone through it is just, treat it like you're playing pool, really try to line up your shot. And I think that really kind of helps people as well. I got a couple different, this is a really cool study that I found. This one's just kind of going through anchoring. And then this one here is really kind of going through, it's like the exact same patient, and they're just kind of looking at different needle angles and just kind of showing how, the more parallel the needle is relative to the ultrasound beam, you're going to see your needle better, which is always a win. So this one is wrong way. If you can get your needle, that needle angle at 55 degrees or greater with an ideal at about 90, you're just going to get a really better visualization. So I always try to, remind people to try to, factor in their needle approach. Another example here, you can see the one on the right better. Why is that? In this scenario, you're, healing or rocking towards a needle. So if you're looking at a deeper structure, if you're going for like a, a deeper peng block or something like that, if you can't really, adjust your needle trajectory, you can kind of rock towards it, which can also further improve your needle visualization. This was a block that I did more recently with a resident. So we were doing a fasciaca block. It was pretty marginal here. It's not pretty at all. And you're like, man, where is that needle going? You really couldn't see it. So we ended up just like re-poking, and we poked, the first poke was kind of right against that transducer. And then the second poke, we kind of, inserted like almost a centimeter off. And you can just kind of see, we see our needle so much better. So I think this is kind of also highlighting too, you don't always have to come right up against that transducer, and you can kind of insert further away and come in flatter to kind of have better visualization. So, I don't know if y'all have seen this too, but I've also had, for some reason, some people think if they just keep jamming the needle in further, that they'll find their needle. So, sometimes you eventually, the resident or whoever you're doing it with eventually finds their needle, and you realize that it's like buried deep relative to where you want to be. So I think one of the things that is kind of helpful to teach people is, if you've inserted your needle like a good 2 centimeters and you don't see it yet, you shouldn't just like keep like advancing your needle. So I've had, I even did a hit ping on someone, and by the time that they found their needle, it was just like buried somewhere in the depths of the pelvis, and I was like, oh, geez, here we go. But I think it's just another thing to kind of remind yourselves of is just try to not do that. One thing that I've also done with residents is sometimes they're looking at their target structure and they don't see their needle. So, we'll have them, kind of very pragmatically say, okay, from your target structure, fan medial. Do you see needle? No. Then move on. But if you see needle, then you just need to aim your needle more lateral to get your needle to your target structure, and vice versa. And then one other thing that I've also found helpful is just, if you can't find your needle, just picking up the probe, completely removing it from the patient, and just setting it along the axis of that needle to kind of figure out where your needle is relative to the target structure. I've also found that to be helpful. And one other thing too that, I think learners are always afraid to do is just re-poking, which I've also found sometimes they just kind of whiff the first poke for whatever reason. And I think sometimes re-poking can be really helpful. And I think that's another big benefit of actually doing a skin wheel. So I don't know what y'all are doing, but I've actually kind of done more skin wheels over time because I think if the resin kind of whiffs their first poke, I think it's a lot easier just to re-poke so you don't feel bad about, re-poking the person if you actually, anesthetize the skin.
What
So that's
what I
something else I've kind of.
what I do for with this, Bob, is I commonly will put my needle, I put my probe instead of bring a. I don't like skin wheels because skin wheels are localized areas. I do a skin line. So where the needle is, I come in like and do a full line because I know they're going to move it a lot. So if
Mhm.
they come in again, they're still not going to shove through because the pain is really from the C fibers in the skin, in my opinion, just from blocking each other. So that has been a useful tool when I see people, especially with inner scalenes and blocks, I know they're going to tilt, they're going to get all over the place. That has helped me in the past for residents.
Nice.
It's funny that
Thanks.
some people, anesthesia colleagues, don't do skin wheels. They think it's interesting that we do. I've had a lot of anesthesia colleagues asking me why I do a skin wheel and they just pop the skin. I think because they're also using a benzodiazepine before they go in, or they use other agents. We tend not to use that many agents. I've used ketamine, but I think the skin line rather than the wheel is really useful.
Nice. Thanks. And this is just kind of also to, remembering to, when you're kind of coming through, is kind of do a little sterile saline to kind of help identify where your needle is. Uh, One thing I've experienced when, I don't know if you all ever have like nurses or anyone else kind of push the meds or the saline for you. If you don't keep an eye on them, they'll just like dump the entire anesthetic or the entire saline. So trying to make sure that they know to do like really small volumes as they're kind of doing this, because you really don't need a lot to kind of make that little tiny pulse to help find where your needle tip is. Kind of next, I want to go through a lot of, there's kind of like some really interesting growing equipment out there and different technologies that kind of really help with needle visualization. So I kind of want to go through some of this. This is the Pad needle. So, I mean, these things are freaking sweet. And I think a lot of other companies have pretty similar needles, but the way they machine these and the way the tips are, I mean, compared to other needles, they're just way easier to see. So, yeah, I think it's really interesting to kind of factor this in. And one thing I think is easy to forget is focusing on beam steering. So if you can't really adjust your angles with the needle angle or with the transducer, you can just adjust the actual ultrasound beam itself. So this is a study that they use like a pad needle with like a stonocyte, and they looked at what actually, in what scenarios did beam steering actually help. And you can see that, at different angles, it can be like the beam steering can actually really help with needle visualization. And when you have some higher angles, actually using the, like more an echogenic or a nerve block needle, that beam steering can be more impactful. So that was kind of a, something that I feel like is easy to forget, but it's something probably worth playing around with on your machines and your institution to kind of see if you can get beam steering figured out. This is just kind of, some machines also have kind of like an AI component to the beam steering. So Mindray has something called iNeedle, which kind of like, almost automatically beam steers until it has the best visualization. So it's kind of one interesting, technology that's out there. I was gonna try to play this real quick.
L12 to 3 VNS transducer in preferred exam mode. Press the eSpatial Navi tab on the left of the monitor to activate. Verify the needle being used is from the approved list in the image tab. Press the calibration button with the transducer approximately 12 inches from the system, the same level as the top of the TE7 monitor. Make sure the transducer indicator notch is toward the left of the screen during calibration. The notch correlates to the M on the imaging screen. A message will appear when complete. Recalibration should only need to be performed once each day or if a different needle is chosen from the list. Magnetize the needle by placing it in the magnetizer with the cap on, all the way to the bottom for a second and pull back out. Notice the trajectory or dotted line on the screen before touching the patient with the needle. For out-of-plane procedures, change angle and degree of the needle to alter the target box location. Advance the needle toward the target. The top yellow dot is the needle tip. Blue indicates the needle is crossing the ultrasound beam, light blue is close to the beam, and orange means the needle has fallen out of the ultrasound beam. For in-plane procedures, the colors mean the same. Once the box is blue, the needle is in plane with the ultrasound beam. Light blue means the needle is close to the beam, and orange has fallen out of the beam. Notice the graphic at the bottom left of the image, which shows the needle orientation in relation to the ultrasound beam.
So, I mean, this is kind of some other crazy new technology, and some of our sports med people are actually using this. So, they're actually magnetizing the needle and then using that as another means to follow the needle tip down to their target structure. I don't know if anyone else has played with this, but I only know people in sports that are using this. Of course, Mindray charges extra for this package too. So, but it was kind of another, interesting thing that I've run across.
Yeah, Zach is asking the question I'm going to ask. I don't know anybody in the EM space that's using this stuff. I've heard about it. People who are just doing procedures all day, like spinal stuff, It just the user interface and kind of the work to do it is such a pain in the ass. That if I just did single plane blocks all day, or I just did spinal injections all day, I think it's a useful tool. I just can't imagine this really flying in an ED setting. I've never had anybody tell me they've used it in an ED setting.
And this is just kind of a summary slide, and I think, one thing is I feel like I haven't seen too many people use beam steering. So it's something else just to kind of consider and try to add to your toolbox, kind of help with your visualization. And then I just kind of love to see what everyone else was doing and try to help their learners kind of get, good visualization to get their blocks in.
Yeah, great talk. I mean, these are all really useful tools. I'd love to hear other people's thoughts, but I can tell you my thoughts on this once everybody kind of says something. Yeah, I think all those things are really useful.
I think a lot of it also has to do with like prepping the learner ahead of time as to what the expectations are going to be. Like you're going to move your probe 10 times more than your needle. And you should like understand that that's going to be the expectation. And then you're going to insert it 1 to 4 millimeters, and then you're going to stop moving the needle. Don't move the needle anymore. Just find it, and don't move needles that you can't see.
Yeah.
It's just facts, right? Like whether it's an IV or a block, don't stab people with needles if you don't know where the needle's going.
So I think this is all going to be fairly moot point, in my opinion. And the only reason I know this is because there are a lot of companies working on this. Once we get away from crystal-based probes, this is not going to be an issue, because beam steering is going to be automatic. It's going to be built in directly to the system, where the thin segment that crystal-based probes offer is going to be gone, and you're going to have a wide footprint that's going to actually find your needle for you, and it's just going to track your needle all the way through. It's going to help you tremendously. There's going to be a ton of like user-based movement on this that I've already seen out in other companies. We're doing it, other companies are doing it, and it's all because of the fact that it's not a crystal with electricity roaming through it, making it vibrate. It's actual chip-based technology. But that's happening. So I think this is going to be, I think in like 5-6 years, I'm hoping we'll be like, oh, this is so obvious. Why did we spend so much time teaching how to find needle tips and how to do out of plane procedures when all of it's going to be fairly simple? Yeah. Anybody have any experience with other techniques that they've used? I personally like I call it the skiing, where you tip the front of the tip down and you push into the adipose just to make it flatter. And I use that all the time. I teach that to residents. They're always like, whoa, that's an amazing trick. Like I've like invented water or something. And it's something that I think really makes a big difference. And I think the difficult people are the ones that are big.
I think the biggest area where I see learners running into issues is just that they are trying desperately to find a needle that hasn't gotten through the skin yet. And they're staring at the screen instead of anchoring their hand and looking at their hands as they introduce the needle into their plane, right? And then since they're not watching the needle go in, they don't wind up on the same plane as the probe, and then you're chasing.
Yeah, you're probably totally right. That's why I think one of the hardest blocks is your distal sciatic, because there's a little space you have to go to, and they get really, really lost. And that's why I'm not a big fan of the Raptor. It's not because of anything else. It's because I think novice providers get really scared of moving a needle through a space where they can't see. Is that what you're saying, Joe?
No, just that when they're actually like initially puncturing skin, that instead of looking at where their hands are going and where the needle trajectory is, they're already head up looking at the screen, trying to see a needle that's not there yet.
Yeah, you mean break the skin first, push it in a centimeter, then look at the screen. That's a really good teaching point. Yeah, fair enough. Yeah, but I do think that there's difficulty when you're not supposed to see a needle for a bit until you catch it. It's a really complicated tool, and I think it's almost grading these as simple, difficult blocks is based on our novice learners and not you and I. Right, like some of these blocks are so simple, I think, but then I see new learners have a real hard time with it. Yeah.
The two things that I tell all residents before doing a block with them is to, number one, that the primary purpose of their non-dominant hand is to be fixed on the patient, not to be holding the probe. The secondary purpose of that hand is to be holding the probe, and just kind of reframing that, because it's so easy for residents to have their wrist up and their whole hand up, and maybe if we're lucky, anchoring with a pinky, and really enforcing that for the stability. And then the second thing I teach which is aligned with what you were saying about the footprint thickness, is with the sonocyte machines using the seam on the side of the probe, which runs down the midline, and using that with a view from above the probe to be able to orient your needle relative to that seam. And then I show them beforehand, before we go to the block, like if your needle is skewed at an angle like this, if you can't find your needle and you go, whoops, I see mine. My blurring is blocking, but if I can't see my needle relative to my probe, and I go diving around like this, I show them why they're not going to see their needle if they do that. And then seeing that beforehand, I think helps them to then conceptualize, if they can't see their needle, the kind of moving laterally and moving medially that you were saying, Robert, in order to be able to find the needle.
Zach, your comment about gates is true. There's this group out of UNC. They published a New England Journal study where they looked at really the idea that you scan body parts, and you don't scan based on anatomy. You take just sweeps of like the entire abdomen, and show it to be efficacious in tons of measurements with AI in the background. So their goal is to build a probe without a screen. I've met with them numerous times now, and so that's their attempt. And they don't want clinicians to be using ultrasound, which I think is smart. I think they're actually thinking of it the right way. They're leveraging it completely as a data collection instrument that something else cleans up and figures out the answer for. I think it's be harder for procedures. There's a group out of Lincoln Labs, out of the Harvard group, that's doing this. I think Dugan was on it. She talked about one of their papers. I met with them a couple of times, and they have a AI procedural tool that is in the field where you literally, they're going to start using it for blocks. I got the name. Autonomous is the name of the company, and essentially it's you walk up, you just push, and the needle is guided by AI into the right spot. So I think there's a lot of push in this direction, and I think there's going to be a lot of simplification of this process. And I think blocks, lines are all going to be the same way that I taught DL. Nobody even does DL anymore, right? I'm like, do this maneuver and try this, and everybody's like, I just shove it in and put the probe, So it's like a completely different art. But I think that's where it's going.
Just dunk everyone in a tub of water, and you don't have to pan scan them anymore. You guys can just with an ultrasound.
But I mean, if you think about it, right? If we're able to scan the lung, there's that nice study that just came out, I think, a few weeks ago with lung, scanning all the different parts of the lung. It was an internal medicine study. I think it was in JAMA or New England Journal, where they just had people scan the entire lung and showed efficacy in all this. And I think it's going to move to the procedural space eventually. I think it's a little harder in the procedural space. I think there's a little bit more stuff to do, but I think these are all just like little bites of the apple. Great talk, Bob. I really liked it. That's awesome.
Does anyone have any special tips, or like how they combine hydrodissection with, towing in or healing in or whatever we're calling it, for really deep blocks like transgluteal sciatic, where like you're still trying to get between fascial planes, but you got a lot of distance to cover? I feel like the peng, you have that like hard surface of the bone to like tell you that you're doing the right thing, and you can see it, at least for the first half, and then you can hydrodissect the rest. But the transgluteal sciatic seems to be a little bit tougher for people that I'm teaching, because they lose that visualization halfway down. I tell them to toe in, I tell them to move the probe out. We try to use the curvilinear probe when possible, but then obviously that has its own drawbacks too. So any recs from the group on that?
On those, I plan to blow an entire flush on the way in. Because then I use it not just for localization, but then also like once you get to this space, then you're pushed, like if you are, actually aimed at the nerve, then you're pushing it away with some fluid as you advance.
And I tell the junior provider I just did one with the PA, like I think it was the last fast track shift I work at. I told her she's going to lose a needle. She freaked out. But once I had the direction, she was directionally competent. She wasn't going to go hit the nerve directly. I knew where she's going. I was kind of okay with it being off because, like, I mean, what are you going to hit? She went in, and then when as she got going in, I'd give a little flush and she couldn't see it. Then she'd fan over. Then it was very poor visualization, but it was kind of close enough. And you guys know that most blocks are close enough. If most blocks weren't close enough, neurostimulators wouldn't be a thing, right? There's a total bullshit. But it's so I think it's close enough counts. But I think if you go in saying this is a deep block, you're not going to see a needle tip. This is going to be difficult. Even for pangs, I say it. And when you see great pangs, like the ones you put on websites, they're always like perfect, right? But generally, you lose the pang a lot. Pangs, transgluteal sciatic. I think for retrospinase too. Retrospinase, everybody. I just passed out an article to the whole group about kind of the belief that retrospinase are probably bullshit, that they're probably vascular blocks. I don't know the answer to this, but I think every time I've done a retrospinase, I have great videos of it, but there's a bunch I've done where needle visualization's poor. I have the same thing.
Most of the time, if I'm gonna do the erector spinae, it's usually in those thinner people. I did have a case where I did it on a guy, and there was a solid 4 centimeters of total hypotenuse distance, and I was told by the trauma center that I shipped it to that it worked out great. So, but if it's just a vascular block, who knows? Maybe that does change things quite a bit.
Yeah. So it's I think the transgluteal, to me, it's just adiposity. So I think people are scared to push a little, and maybe I'm just much more forceful. My being able to push into the, like giving a massage almost, like push right into the sciatic nerve as hard as you can, not as hard as you can, but put a little effort. I've had a lot of people who are really gentle. The hard part is when you do that, the probe sinks, and then somebody has to push the skin down to pop under the skin, which is a real pain in the ass. I joke.
The other thing I think helps with the sciatic is to actually like bring the knee up quite a bit if the patient can tolerate it. But if you have them with their hip and knee extended, then it just gets deeper and deeper.
Yeah, good point. Yeah. Bob, you're the people that are using the Mindray product, they like it? They feel it's useful, good. Are they beginners, or I mean, because usually sports people, excuse me, are usually pretty proficient with ultrasound. I don't know how good they are with injections.
Yeah, I haven't talked to that person in a lot of detail, but I just know that they, went through the whole process of buying all that. I didn't hear like a lot of like feedback on their experience with the, that space and nav, but so I know that at least they're like, buying the package and using it. But yeah, so I don't have a lot of great feedback on how it actually was.
We can ask Mindray when they come to BlockHeads this time, but I think it's been a huge loss for Sonosite. They bought this company that did central access really quickly, and they had another one, and both of them were like $5-10 million losses for them. They just scrapped the product. So I'm surprised that, I mean, I'm glad Mindray is doing it, but I just think that it's the people who are going to end up doing it are people that are building chip-based probes, just because it's gonna be it's so hard. Yeah, interesting. Great.
Cool.
Well,
Any
thanks
last
everyone.
Only other thing I have is we're starting up an ASAP ultrasound subcommittee for blocks. So I just sent out an email via ASAP. I'll throw the link in the chat here too, for signing up for that. But the goal is basically going to be to build practice guidelines for like everything, from antisepsis, probe covers, local anesthetic toxicity protocols, all that kind of stuff. And then also to develop like a Plan A block guideline for the ED. So all the kind of stuff that you guys are already talking about in this group, but to try to put ASAP's name behind it for folks that are starting up block programs.
Yeah, and we've purposely, at least I've purposely kept this off of ASAP. They've asked us to join. I've purposely kept it separate just because of a lot of Uh,